Hello, everyone. I'm Tom Davis, Global Sector Lead for Health and Nutrition for World Vision International. Today is August 31st, 2020, and this is a presentation on interpersonal psychotherapy for groups as part of the Community Health Worker Core Project Model virtual workshop. Let's talk a bit about the description of this approach to begin with. So what is interpersonal psychotherapy for groups? I imagine one reason that we as practitioners have not done as much in the area of mental health and psychosocial services is because we feel like it is outside of our skill set. There are pharmacological approaches to depression that may be outside of what World Vision can do in a project. But we do have project models such as IPT and Problem Management Plus that have been used by World Vision and other international NGOs successfully to treat depression, albeit often with some support from others, such as academics, who are more versed in community-based treatment of depression that are very willing to work with us. One of the most effective models for this is interpersonal psychotherapy for groups, or IPT. And my connection with this model is that I developed a concept for an IPT research project in Uganda, and then helped backstop it, and we completed that CRCT back in October of last year, in 2019, along with Food for the Hungry, the organization that led on implementation. I'll be the senior author on that paper when it comes out. And with IPT, you take the depressed individual, male or female, through 3 months of weekly meetings in groups of about 8 people, led by a trained paid staff member or a community health worker or some other cadre that we'll discuss, which it's usually called the IPT promoter. This IPT promoter is not a psychologist usually, but only has a little college or college degree or some other qualification. And they're trained for 2 weeks daily on how to do IPT. And with IPT, you encourage a depressed person to regain control of their mood and functioning. The IPT promoter helps his or her groups to understand that depression is largely triggered by interpersonal difficulties, that is, between people, in 4 different areas. So you help people to identify the link between these triggers and how they feel, and to learn ways to deal with these 4 problem areas. The first problem area is grief. Depressive symptoms may start around the time or shortly after the death of a loved one or someone who has played an important role in the person's life. In normal grief, grief reactions that may look like depressive symptoms usually go away within a few months. However, when symptoms persist and affect the person's ability to function, then the person may have depression, and if so, could benefit from group IPT. With grief, the goals of therapy are to help the person to mourn the loss of the loved one and to find other activities, social roles, and people who will help to make their life better. Sometimes the problem is interpersonal disputes. The people involved can be fighting openly, or they may never acknowledge the conflict, however significant it may be. For example, a husband wants more children, but his wife does not. Maybe a neighbor is stealing, but the victim cannot prove it. Or maybe a person's boss gives a better job to someone else who has only recently been hired, and the person believes that this is unfair. In the case of disputes, the goals of therapy are to help the person to figure out what they and the other party want and expect, to develop new skills for communicating effectively with the other party, to practice those skills, and to mobilize people who can help bring about a resolution of the conflict. Sometimes the trigger for depression is role transitions or life changes. These include things like a woman getting married and moving to a new home, a spouse who wants to separate, a person learning that they have a serious illness, caring for someone who is dying, moving away from the family or retiring, marriage, childbirth, poverty after the death of a household earner, separation or rejection by a lover, or becoming a refugee. All of these transitions in a person's life. And in the case of life changes, the goals of IPTG therapy are to help the person recognize that they are experiencing feelings such as sadness and anger, or confusion or powerlessness about the change, and to examine what is positive about the change or its potential for growth and meaning, and to learn the skills necessary to manage that change. And lastly, to support to make the change easier, getting that support that's needed. Another trigger is interpersonal deficits, things like loneliness and social isolation. Now, this one is less commonly found in Africa, but with this, the person has a history of problems in beginning or maintaining relationships with friends, relatives, or others. The person talks about feeling lonely and separate from others. And although these feelings are long-standing, they may become worse after one of the other problems surfaces, such as a move to a different town for a new job, or the death of a friend or relative who used to be central in bringing people together socially. So in the case of loneliness and social isolation, the goals are to help the person find out what contributes to their loneliness and guide them to make friends by learning how to begin and maintain friendships. Let's talk some now about the evidence for this model. So why are we proposing scaling up of treatment of caregiver depression? And then after we've talked about that a bit, let's talk about the evidence for IPTG as a way to do that. So we have plenty of evidence now that depression is a major unaddressed problem in most of the places where we work. We know that depression is not just a problem in industrialized and high-income countries. The prevalence of maternal depression, for example, is between about 15% and 57%, depending on the country where it has been studied. WVI Uganda and Johns Hopkins University found that 21% of adults in HIV/AIDS affected communities in southwest Uganda were clinically depressed. And in the study that we just finished in October, we found it was about 30% of caregivers of young children. And I've heard recently that WV Ethiopia found it was about 30% as well. Women do suffer twice as much depression as men, and mothers of young children are at an even greater risk. Men sometimes express depression as anger, by the way, so it looks a bit different in men sometimes. We know that postnatal depression has a significant negative impact on behaviors such as breastfeeding and on child development, such as delayed psychosocial development and behavior. And maternal depression is in the perinatal period is linked to a wide range of adverse child outcomes, including compromised physical and cognitive development, behavioral difficulties, and increased risk for later common mental disorders in children. But depression doesn't just affect behavior. We know that infants of mothers with depressed symptoms have a higher odds of being stunted, and that the causal relationship between household food security is bidirectional. That is, experiencing food insecurity makes it more likely that you'll become depressed, but independently, being depressed makes it more likely that you'll become food insecure. And other studies show compromised parenting behaviors are often linked with depression as well. And on this slide, by the way, I've included in the notes section the citations for some of these studies I've mentioned here. So feel free to download the slides to see those studies. Just understanding the suffering that goes on with depression should be enough reason that we should want to intervene, but we now have multiple studies showing this linkage between maternal depression and growth of the child. We know that maternal depression in the perinatal and postnatal periods predicts poor growth and a higher risk of diarrhea in infants, and that major depression in the postpartum period and current major depression are associated with malnutrition in the child. There are strong associations between depression and high rates of preterm birth, low birth weight, and restricted fetal growth. And a 23 systematic review for perinatal depression interventions conducted by non-mental health specialists in low middle income countries show that feasibility and effectiveness of the interventions with a moderate effect size. That's one reason that both IPTG and Problem Management Plus are endorsed by the WHO. The most striking finding for me, though, was Pamela Surkant's meta-analysis in 2014, which found that elimination of maternal depression could result in a reduction of stunting of 23 to 29%. She concluded in that our findings indicate that a reduction in the incidence of maternal depressive symptoms in developing countries would not only have a beneficial effect on mothers, but would also improve child growth and sustainability. This is one of the reasons that World Vision is so interested in helping to scale up mental health and psychosocial interventions. Let's remember, too, that mental health interventions are even more needed now during COVID-19. This graph shows the recent self-reported stress levels in 2 regions of Ethiopia, with about 35% of people in Amhara and over 85% of people in Oromia, where there's a lot of social unrest as well, reporting the highest level of stress possible on the scale. Note that World Vision Uganda project final evaluations found that there was also a reduction in risk-taking behavior and suicidal thoughts amongst IPTG group members from a pre-assessment level of 25.7% down to 4.5% by final. This is very important during COVID, that we have where we have seen suicidal ideation, thinking about killing yourself, going up dramatically in some countries. Concerning the evidence for the IPTG model, World Vision has led the way on some of the testing of it. World Vision and researchers from Johns Hopkins School of Public Health and Columbia University Teachers College have been our main partners in this. Linda Verdelli and Paul Bolton did a randomized cluster trial of interpersonal psychotherapy for groups in 2002 that targeted depressed adults in South Uganda. They did a later study using IPTG for depressed adolescents in refugee camps in North Uganda with World Vision, many of whom have been child soldiers. And in the RCT in Uganda, after the 4-month intervention, depression dropped from 86% to 7% in the intervention group, which is a 92% relative reduction. It dropped less in the control group, but some depression does resolve on its own over time without intervention. The researchers also saw significant improvements in functionality and household tasks as well. Things like being able to cook and care for one's children. And a separate sustainability study was done 6 months afterwards that found that those results were maintained. IPTG may also help to address adolescent suicide in lower middle income countries, which was found recently to be much higher than we originally thought. A Lancet report in April of 2019 found that 17% of adolescents in LMICs, almost 1 in 5, reported making a suicide attempt during the past 12 months. It's very concerning. Here's what the depression scores looked like in that southern Uganda trial at baseline after the 3-month treatment and at 6 months. It was highly sustainable. But what is particularly interesting to us as an organization is its effect on behavior change, a child's education, and a person's ability to do farm work and to provide for their family. It's hard to believe that someone can be just as productive on a farm or in raising healthy, well-nourished children when they say, I feel down, depressed, and hopeless, or I feel tired or have little energy, or I have thoughts that I would be better off dead, or about hurting myself in some way. These are all statements that people often say yes to when they're depressed. Think of the impact on that across sectors. And indeed, in an IPTG study in 2016, the researchers asked families who had been treated using IPTG what changed for them, their families, their children, and their whole community because of the IPTG groups. And these were both men and women, caregivers. And the main things that they mentioned were all things that are important to us in World Vision. Improved school attendance for children, so education changes. Improved productivity, livelihood changes. improved sanitation in communities, wash changes, greater cohesion among community members, and reduce conflict in families. So child protection changes as well. What was missing from these earlier studies about depression was to connect the dots. We know that depression can affect behavior change and hurt child growth. We know that IPTG can rapidly reduce depression in developing countries. What we have not demonstrated is that this intervention to reduce depression, IPTG, will improve behavior change and improve child growth. World Vision, through my participation, and Food for the Hungry, tested this hypothesis in that project using IPTG and care groups in Kitgum, Uganda, from 2016 to 2019. And that study was led by Food for the Hungry, but in collaboration with World Vision, Johns Hopkins, and Columbia Universities. World Vision and Food for the Hungry in that study, once again, some of you have heard this before when we presented it separately, but we found that the depressed women who were treated with IPTG had a greater reduction of depression than those in the comparison arm, which confirmed our first hypothesis. IPTG works to reduce depression. However, this difference attenuated after depressed women were reached in care groups twice a month for about 15 months, to the points where the difference was no longer statistically significant. Surprisingly, women who only received the care group behavior change intervention had a decrease in depression of 95% by 21 months post-baseline. The researchers on our team agreed that this may represent a strong therapeutic effect of the behavior change intervention itself, the care groups, and it may be due in part to behavioral activation, that is just getting out and doing more, and also the increased social support that they could have from the care group meetings that they use there. We also looked at functioning impairment, where mothers are asked, how difficult have these problems made it for you to do your work, take care of things at home, or get along with others? And we saw an improvement, that is a decrease in that indicator after IPTG treatment at midterm, and it remained lower by inline. So it did help people, IPTG helped these mothers of young children, these caregivers, to be more functional in their role as a caregiver. This analysis also confirmed our second hypothesis as well. Women who received IPTG treatment had significantly higher adoption of 1/3, that is 4 of the 12 health, nutrition, and wash behaviors that we promoted. Those are the circled ones here. After treatment for IPTG, before we even promoted behaviors, mothers were more likely to endorse giving the child iron-rich foods. They said they were washing their hands with soap, including having a presence of a hand washing station in the home. They were properly disposing of child feces, and they were using family planning in greater numbers than the women who did, the depressed women who did not receive the treatment. The endorsement for these behaviors was about 23 to 32 points better relatively, or percentage better relatively, or about 7 to 13 percentage points. These are preliminary results. They haven't been published yet, so they could be changed, but this is what we're seeing so far. And you should remember this slide from the intro presentation that I did earlier, which shows the behavior endorsement of women who were no longer depressed after the IPTG treatment, the green bars, versus the red bars for the women who were still depressed after treatment. You'll note you don't see any red bars because they're all 0%. This was very striking to us, realizing that for all of these that we could assess, 10 of the 12, women who were still depressed even after treatment, and those who were never received the treatment and were depressed, didn't endorse any of these behaviors, where you had much better adoption of those who were no longer depressed. So let's talk about the extent of rollout and the cadres and different types of community health workers implementing IPTG. In Uganda, we have IPTG programs that were developed and implemented, particularly amongst people impacted by HIV/AIDS, but also up in the north amongst women who were just depressed and caregivers of young children. IPTG promoters are used who have completed secondary school, and some often have some college but not college degrees. But it's been mixed in terms of like who actually implements it. It's never psychologists, but sometimes it's even people like community facilitators. So in terms of cadres, IPTG has been rolled out by IPTG promoters, community facilitators, such as in Ethiopia and the Democratic Republic of Congo, child protection staff, that was done in Myanmar, and even through Christian pastors and leaders in Haiti, even though that has not been evaluated yet fully to know how that helped, and volunteer facilitators in Ethiopia. Also in Ethiopia, the SPEAR food security program has community health and IPTG facilitators in most of 94 Kabyles, and plans to also use Problem Management Plus in half of these Kabyles, training both CHFs and volunteer facilitators. Problem Management Plus would then be used in all of their visa groups in year 2 of SPEAR 2, so they're doing a pretty big test of it there. IPTG has also been used by World Vision in Kenya, DRC, South Sudan, Haiti, and Myanmar. And in DRC and Myanmar, World Vision targets children above 13 years of age. And in Haiti, IPTG groups were formed amongst those who acquired a disability due to the earthquake. And a Christian spiritual nurture component was incorporated into IPTG there. This included training of pastors and Christian leaders as IPTG facilitators. In terms of some successes we've seen, apart from the evidence we've seen of this model, the IPTG program in Haiti, where a high number of people were disabled by the 2010 earthquake and displayed lots of symptoms of depression. And in one of the camps, World Vision formed IPTG groups, especially targeting those who had acquired a disability. So this is one thing that we can use with people who are disabled, especially when we see higher rates of depression amongst them. The World Vision Haiti earthquake response also piloted the incorporation of a Christian spiritual nurture component into IPG, as I mentioned. As part of group therapy, participants' spiritual needs were also addressed in IPTG sessions, and findings about whether or not this resulted in further reduction of depression symptoms compared to IPTG groups that did not have that focused spiritual nurture is yet to be analyzed, but it's a very promising practice at this point. Given the success of World Vision's earlier IPTG pilot project in Uganda, IPTG has also been rolled out in numerous other African countries, including Kenya, Democratic Republic of Congo, Malawi, Zambia, South Africa, and Lesotho, bringing equally positive results. So some of these countries, it's been done by other INGOs based on World Vision's earlier work. So we're kind of the main INGO that I know of working with IPTG. And we're partly responsible for the fact that it has spread in many countries in the world. World Vision is also supporting rollout of MHGAP, the MHGAP intervention guide and program in the post-conflict area regions of northern Uganda. MHGAP focuses on capacity building of primary healthcare workers and systems, and the project also integrates IPTG and supporting user groups of the services to be actively engaged in advocacy for the needs of people with mental, neurological, and substance use disorders, or MNS disorders. In terms of the challenges, there are some challenges with scaling this up and using IPTG. One is a lack of MHPSS staff to provide the necessary training and clinical supervision for community facilitators. So we often need to bring in consultants for training and also do some training of clinical staff if they have no formation in mental health and psychosocial services. Also, dealing with suicidality can be an issue. For people who say that they have thoughts that they would be better off dead or thoughts of hurting themselves in some way, and when they have a plan for ending their life, you need to get a mental health professional to see them right away. I think that was about 3% of the caregivers we surveyed in Kitgum, Uganda, that said that they answered yes to the PHQ-9 question about suicide and said they had a plan for suicide. There, we had a referral network, but it's more difficult where you don't have a referral network. So this might be a lot more useful in areas where we already know that there is some sort of referral network. With COVID-19, it's now allowable to do that consult to see if you do need to get a person into a facility over the phone. So that makes it a bit more easy to do when it used to be the person doing the survey just had to wait at the house until they could get someone to come who could actually do that assessment. Also, ensuring sustainability of IPDG services after projects. So sustainability of the services itself, not the results, can be a real challenge. The groups often keep going, but not the support to those groups. 6-month follow-up studies showed that depressed people remained, the depression basically remained low among group members in Uganda, so that's a positive. But we need to think about what is post-IPG, what is our follow-up mechanism? Because a follow-up mechanism is necessary to ensure children's and caregivers' mental health and psychosocial needs continue to be addressed and they're not neglected once World Vision's engagement ends. Comorbidity can also be a problem, where depressed people also have other psychological problems that are not addressed as well by IPDG, things like anxiety and schizophrenia. And of course, some clients will fall back into depression and experience a relapse regardless. And during disease outbreaks like COVID-19 and Ebola, implementation of group activities are not always possible, which can make it hard to implement IPDG. This intervention requires face-to-face interaction. For example, we have a budget for IPDG implementation under the MHGAP work in Iraq right now, but we have not been able to begin implementation due to COVID restrictions. And if that continues in October, then they'll have to drop the IPDG and replace it with something like Self-Help Plus, another model. Let's talk about some recommendations for how to support this in World Vision. And most of these and some of that earlier information I presented to you on Scale Up was graciously provided by Fiona Coryett, who is a real guru around mental health within World Vision. So, as I mentioned, Fiona has told me that the way to bridge the gap for mental health implementation, there's several things we can do. And one is to ensure that our field offices prioritize mental health since mental health funding is available. They need, the field staff basically need to engage with in-country and global mental health and psychosocial donors so that they can access funding and staffing for this. Fiona is working on ensuring that World Vision has funding for MHPSS staff in the countries where she deploys, but that's not every country, of course. We have a survey on mental health and psychosocial services that field offices are completing this month to better gauge their current work and interest in mental health, including IPDG. We also need to partner with religious institutions, such as churches and mosques, that allow a degree of community ownership whilst also building the capacity of spiritual leaders to address the mental health needs of their community members. This can be done through selecting some IPDG facilitators from within the church or other spiritual institutions in the community. DRC is a good example of where we've actually done that. Facilitators should also ideally come from the community in which the group is based. This helps ensure that the expertise gained remains in that locality once World Vision's engagement has ceased. World Vision should also implement a follow-up mechanism after IPDG is introduced. This may be through the encouragement of groups to form their own CBOs and to continue relationships formed within the groups. In Uganda, the IPDG program was sustained by members of those groups registering their groups as CBOs once World Vision's involvement in the groups had finished. I visited a couple of those groups. This not only allows the benefits of IPTG to continue, but also can result in the group members having a true sense of ownership over their group. These groups sometimes end up working on other issues that can affect their mental health as well, such as livelihoods. Another avenue is to provide an ongoing forum for individuals to voice personal concerns and successes after the IPT treatment is done. And if possible, an informal relationship between World Vision and the CBO should be maintained in case there are any significant follow-up concerns. In addition, it may be possible for a partnership with local universities to be developed. For example, university psychology clinics, which allow students to continue with programs or groups longer term. It's also important to ensure a referral mechanism is in place should any participants relapse and require support. Referrals should be documented for either clinical or non-clinical supports. I know we have a number of models that we will be considering for mental health and psychosocial services, IPTG and Problem Management Plus, for example, and I'm hoping that we'll leave room for field offices to use IPTG and their programs as a community health worker service package. While IPTG is often considered the Cadillac of mental health and psychosocial support models, it's one that some field offices will choose to use and have chosen to use. Thank you.